All right, let's move now into assessment and treatment. Largely, assessment of dysphagia in cancer patients, those strategies are going to mirror just our general assessment strategies, procedures that we use in dysphagia, and we're going to cover those a little bit in the future. But there are some considerations that are specific to the cancer population, the timeline of the surgery, timelines of radiation, timeline of chemo, as well as the extent of the surgery that's going to take place, as well as the extent of the radiation or the chemo that the patient is going to have to go through. Those are things that you have to keep in mind because those are going to impact the patient's swallow and their ability to, and their desire to take food. One of the things that you look at specifically in the cancer population are called impact factors. And these are things that we've largely already talked about. But these are like factors that have a large impact on the patient's ability to swallow and the patient's ability to take food orally. Pain during the swallow, odynophagia, xerostomia, fibrosis, like we've already discussed. You can see here, this is a questionnaire coming from the University of Michigan that you use to get the patient to rate their level of the impact that the xerostomia is having on their lives and on their ability to take food. As you guys already know, probably just from general exposure to the idea of cancer patients and cancer treatment, malnutrition is a significant factor for anyone going through cancer treatment. Everyone in their mind probably can think of some movie or some personal experience where you have seen a person go through cancer treatment and lose a great deal of weight. That weight loss, that malnutrition comes from a lot of different factors, many of which we've already discussed: the difficulty swallowing, the lack of the desire to eat, the lack of hunger, the altered sense of taste and smell, as well as pain during the swallow, xerostomia, trismus, fibrosis, all that stuff. So you have to be aware of the possibility of malnutrition, of the patient not being able to take enough food. We do our best as SLPs in charge of swallowing to work against that, to facilitate the patient being able to receive enough nutrition. But ultimately, we're not the ones monitoring nutrition. That's a medical issue. As SLPs, we're sort of at the intersection between appropriate nutrition and malnutrition because we're the ones that are working with the patient on their swallowing. So you try to do what you can for the patients to minimize the negative impacts that they're experiencing and try to maximize their nutrition. So there are specific head and neck cancer screening tools that we use. The MD Anderson dysphagia inventory looks at their quality of life and how their dysphagia is negatively impacting their quality of life. There is the Mann Assessment of Swallowing Ability Cancer. This is different from the regular Mann assessment. So we have a few of these, but essentially these are just questionnaires that the patient fills out, or maybe you present verbally to the patient to get an idea of what problems they're having. And then maybe once you know exactly how, once you know the negative impacts they're experiencing, once you know the problems they're experiencing, then maybe you could come up with some way to negate that. As I've already mentioned above when I was talking about therapy for fibrosis, what we've gotten to now is that patients begin therapy at either before surgery or after surgery as quickly as possible. And if radiation comes after surgery, which it probably will, then patients need to, then the gains that the patient made in their swallowability after the surgery. So let's say patient had part of their pharynx removed, and then directly after that surgery, you go in and you work with them for a few weeks to restore their ability to swallow after their surgery. But now they have to go through radiation. Radiation is going to present with all the negative impacts that we've discussed, which will oftentimes cause the patient to lose what gains in their swallow they made after their surgery. And also, as mentioned above on the pharyngosise slide, patients in this stage become very unmotivated, very non-compliant with therapy, very discouraged, and that's understandable. So, once again, you can have dysphagia that is the result of surgery, or you can have dysphagia that's the direct result of the radiation, or both. As we already mentioned, patient compliance with therapy, especially when going through radiation, chemo and radiation, is going to be a problem. So at this point, as an SLP, you have to try to find ways to increase the patient's compliance, their adherence to the therapy or the exercise program for their swallowing. And this may involve strategies such as creating a contract, a written contract with the patient that they will complete, that they are agreeing to complete these therapy exercises. And this is something that we often do. We usually do the written contracts with kids with autism as well as adults. For normal developing child might completely disregard the written contract, but for adults, they sense some investment in the contract and they want to adhere to it, as do the children with autism. They see the contract as basically as some form of behavior schedule that reaches into time, and they don't want to necessarily break that schedule. Also making like a daily schedule for the patients. You saw like the score sheet above for the pharyngosise program. Having those in place makes it more concrete for a person, which makes it seem more doable. And that is another strategy that can increase compliance. All right, so let's get into bolus transport problems following head and neck cancer. So largely when we're talking about this, we're talking about anatomical differences that are the result of a surgery to remove the cancer, or maybe we're talking about fibrosis of musculature that is negatively affecting mandible, the tongue, possibly the velum. So for those patients that have had tissue removed and there's now just a lack of that in the oral cavity, potentially a lack of hard palate or a lack of soft palate, there is what's called a nasal or palatal obturator. And basically this is exactly what it sounds like. This is a prosthetic that goes in and plugs that specific hole that has been left by the removal of tissue by the surgeon.
Of mine many years, and Diane had a tumor removed from the front of her mouth. I'm going to show you. It goes all the way up to the base of her nose. Open wide. All the way up to the base of her nose. She has a communication between her mouth and her nose. And Diane's going to speak now without her obturator prosthesis in to let you see what it's like for her to speak. She's going to tell you what life might have been like if she never got this prosthesis and what she would have done with her family. And I want you to notice how her upper lip is collapsed because there's no support from any bone or teeth in that area. Okay?
Hi.
Hey, Diane.
Yes, my name is Diane. I had a cancerous tumor removed about 14 years ago. I am so grateful whoever invented this prosthetic piece. If it wasn't for that, I would be lost, sad, very depressed.
Okay, now I'm going to put the prosthesis in, Diane, so
Yes.
they can hear how you speak.
Okay.
Open. Okay.
Ah, so beautiful.
See the difference in her speech and her lip?
My lip, I can speak. I can do everything with this. I can eat. I can chew. I can put my lipstick on so nice. There's so many things that I can do with this. If it wasn't for this beautiful person over here and the whole staff.
So you can see how the obturator allows her to eat, it allows for mastication, and that she wouldn't be able to do with that exposed hole in her mouth. And it allows for appropriate speech and resonance. And here's some palatal lifts. And the palatal lift is essentially, as you can see, you have this extension that goes back under the soft palate, and it functions to help the soft palate approximate the posterior pharyngeal wall. So you would use the palatal lift in the case of velopharyngeal weakness, perhaps. So you would use the palatal lift in a case of velopharyngeal weakness where the velum is unable to approximate the posterior pharyngeal wall, or maybe if part of the posterior pharyngeal wall had been removed and the velum needed a little bit more help to be able to approximate that for an appropriate swallow, to seal off the nasal cavity for an appropriate swallow, and also for speech. All right, sticking with difficulties with bolus manipulation and AP transport, there's a device called a glossectomy spoon, and this is exactly what it sounds like. It's a spoon for patients that have had their tongue or part of their tongue removed, and you can imagine that without the tongue, there is no appropriate AP transport. So the spoon is essentially this device where you have the bolus on the front end, and you're able to insert the device all the way back into the oropharyngeal cavity, the oropharynx, and then you push the button and it pushes the bolus off of the spoon, basically right into your pharynx. For those patients that don't necessarily have a glossectomy, but are still having difficulty with bolus manipulation or AP transit, and you want to put into place some strategies, things that we use are range of motion exercises. So perhaps the tongue has lost some range of motion through treatment, through radiation. So you would do a lot of slow stretching of the tongue, which would look like you holding, or the patient holding their tongue with some gauze and pulling it slowly one way or the other, up and down. And this is not quick, because when you pull the tongue quickly, that cues the stretch reflex, which increases tightness. Slow stretching, which decreases fibrosis in the muscle and decreases the tightness of the muscle. Use of feeding devices like the glossectomy spoon, as we just mentioned above, dietary changes. So clearly someone who is having difficulty with bolus manipulation, with AP transit, they're not going to be eating steak, right? So dietary changes, them eating consistencies that are more easily transported posteriorly, so things that are more wet, things that are more pureed. So probably what we're talking about is a pureed diet, or at least a mechanical soft diet. Mechanical soft is just, it's like a banana. You need to chew it, but it's still soft and wet and chewable. Changes in head posture to help protect the airway. Changes in head posture to facilitate AP transit. And the primary strategy would be a chin up to facilitate the using gravity to pull the bolus into the pharynx. The chin up strategy is outside of this situation and maybe a couple other situations. It's not something you do. Usually we do chin down. 99% of the time when you're working with dysphagia patients, you're going to be teaching the chin tuck, not the chin up. But in this situation, it would be appropriate.
My name is Jerry, and it would be 3 years in January that I had a total glossectomy.
Technique for swallowing after a total glossectomy. First and foremost, it is important that you use a bottle. With a bottle, you can control the amount of fluid that you swallow. I use a glass Starbucks coffee bottle. Before you begin your drink, find a comfortable place to sit. Place yourself at an angle. That helps the fluid go down. Do not move the position of your neck until you are finished, as you want the fluid to go straight down. Think of your mouth as a funnel. Pour the liquid in until your mouth is full. Close your eyes. It helps to have no distractions. Gravity pulls the fluid down. Open and close your mouth. Opening allows the fluid to go down. As you become experienced, you may add applesauce with your tube food. Pumpkin can also be used. Add a touch of nutmeg. Eventually, you can use cooked oatmeal with peanut butter. This should be thin enough to pour through a funnel. Cook the oatmeal. When hot, add peanut butter and refrigerate. All items you use need to be cold or at room temperature. Never use hot items.
So never use hot items, because obviously you can burn yourself, and there's a good chance if you're having motor difficulty, then there's going to be some sensory difficulty as well, and the patient may not feel it. So you never want to encourage people to be drinking hot stuff. Also, the supraglottic swallow is a strategy that this population uses a lot. And essentially what the supraglottic swallow is that after the swallow, so you adduct the vocal folds prior to your swallowing, and then after you swallow, you throw a cough in there. That's going to expel anything near the vocal folds. So it would be like, we've talked about syringe feeding in relation to dementia patients, and I said it's hopefully out of fashion still, although you probably will encounter people wanting you to do it at times. But for your head and neck cancer patients that lack AP transit, then syringe feeding may be appropriate, because you could get the syringe back far enough to the pharynx.
For all of you people out there who are thirsty and who want revenge, in the morning I love a cup of coffee. Now I have it as a benefit. It was my whole
She's going to display this going wrong.
but if you want it, I mean it later. If you want it, what you do is take a drink out of the cup, right? Like this. What the
She can't manage it.
I can't even swallow it. If I do that, maybe some
So she's lying back.
love, but no. Without a tongue, you can't even drink the coffee.
Without a tongue.
What I have to do is take a syringe and I suck up the coffee like this. Alright, here's coffee and the syringe. Alright, this is how I have to drink. Then I have to take one of these French tubes, and this is what I do. If I am thirsty, but I'm not a cup of coffee, or a glass of water, I have to do this.
So she's going to thread to the back of her throat.
And lay down. And that's how the only way I can drink.
All right, so moving on now into preventing fibrosis, treating fibrosis. As already said, slow stretching range of motion exercises are used. This would be for the lips, for the tongue, for the mandible. Exercises can be passive, meaning the patient themselves is pulling, passively moving the structure with their hands, or active, where you're actually engaging your muscles to move the structures. And we saw the Dynaspint system in the previous slides. The Therabyte system, there's an image behind my window here showing you what that looks like. There it is. It's a very similar device. And these are two devices that are used to passively increase the range of motion of the mandible. Another strategy, and this was also mentioned in the video above, is that the doctors will tell the patient, okay, I want you to be able to put like stack three tongue depressors and wedge them in. And then tomorrow, I want you to wedge in 4 tongue depressors and maybe stay at 4 tongue depressors. Do that for a couple days. And then maybe next week, wedge in 5. And so maybe they're getting that in a couple times a day for like 10 minutes at a time. Slowly increase the range of motion, and it's very painful. Any treatment for trismus would be very painful.
I'm going to shorten this up a little for the purposes of this video because this is kind of painful when I actually do it. And I want you to put them in your mouth. Like so. He says, now what I want you to do is I want you to put as many in there as you can stand. And then I want you to put one more. And then I want you to keep them in there as long as you can stand the pain, and then 2 more minutes. And then I want you to add another stick every day. So, well, I'm kind of as close to those instructions as possible. We're running at about 10 to 11 minutes that I have to do this every day. And basically, like I say, I start jamming these in, and then I fit the rest of them in the middle to pry it apart. And I have to do that every morning. I do it twice a day. I do it every morning and every evening. And my goal right now is 10 minutes. Sometimes I'm able to go 11 or a little more.
So you get the idea. So here are some strategies for trismus. So obviously, following surgery to the pharynx, there's the possibility of the patient acquiring some airway protection difficulties. So the treatment that we will do for that will focus on facilitating laryngeal closure, so increasing the adduction of the true and the false vocal folds, or possibly improving the coordination of the swallow to keep the bolus more out of the airway. I'm going to skim over this information on surgery, which is a thyroplasty. Basically, they just go in and they put in, either inject something or put a little plastic device in there to create a bump there where there used to be a vocal fold, or to help pull the paralyzed vocal fold closer to midline for appropriate adduction. Behavioral changes that we do for airway protection, and this is sort of the same as what we're going to cover in the future. So these aren't particular to cancer patients, but as I already said, tucking the chin down, possibly if you have one side that is the weakened side, rotating your head toward the weakened side, or if you have one side of the pharynx where tissue has been removed, then rotating your head towards that side where the tissue has been removed, which pulls your intact side more to midline, so that when you swallow, the bolus is going to move along that intact side of your pharynx more than on the impaired side. Here are 3 strategies: the supraglottic swallow, which we've already defined, the supraglottic swallow, which is essentially you take the supraglottic swallow, which is adducting the vocal folds, swallow and cough, and then you add a effortful swallow, a hard swallow to the supraglottic swallow, and that is the supraglottic swallow. We're going to come back to that. And there is also something called the Mendelssohn maneuver, which is an exercise that we use to facilitate hyolaryngeal excursion, meaning the larynx being pulled up. During the swallow.
Swallow your saliva a couple of times and pay attention to your neck as you swallow. Feel your voice box lift during the swallow. On the next swallow, keep it lifted with your neck muscles for several seconds. Relax and try to repeat this 5 times.
So that's the Mendelssohn maneuver. Basically, you learn to hold your larynx up in the middle of a swallow, and then drop it down, and it's very effortful. And what you're doing is you're exercising those suprahyoid muscles, those hyolaryngeal elevators, and you're making them stronger, which is important because you want to be able to pull the larynx up to meet the epiglottis. There are a lot of strategies to deal with xerostomia for patients going through radiation treatment. Some patients will simply chew gum. They have special gum that's like really sour and really bitter that will cue saliva production, because that's when we talk about xerostomia, that's what we're talking about, a lack of appropriate saliva production in the mouth. There are artificial salivas out there that the patient will spray into their mouth to keep things moist and wet. And you need the mouth, the oral cavity, to stay moist to keep those tissues in the mouth healthy, to keep your teeth healthy as well. For the treatment of mucositis, and this is sores in the mouth, this is a medical issue. It's not nothing. It's not something that we as SLPs deal with, but oral analgesics, meaning those medicines that reduce the pain in your mouth. The patients need to keep their oral cavities as clean as possible if they have sores in their mouth, obviously. And what you see down here these are toothaches. It's like a sponge on a stick. The surface of the toothache can be abrasive. And usually this is the go-to tool for cleaning a patient's oral cavity. But there can be too much friction between the surface of the toothache and the dry and maybe lesioned oral tissue. So you don't want to encourage the use of toothaches in people with the dry and painful inflamed mucosa because it's too abrasive.